So we'll start with going over some demographics and then go into a case presentation. We can then talk about staging and current treatment options, and then a few thoughts on things moving forward for the future. So this is a patient that I met back in October, actually it was November of 2019. She was a 58-year-old female. She initially presented to her PCP with a 1-month history of abdominal pain. She was actually going back and forth between DC and she had a home in Hawaii. And she attributed her pain to carrying suitcases and thought it was musculoskeletal. On review of systems, she noted 10 pounds of unintentional weight loss. She had some blood work, including a metabolic profile and a CBC that were within normal limits. And of note, she had recently been diagnosed with diabetes. So the question is, if you're seeing a patient like this in the office, then what do you do? We'll come back to that. So pancreatic cancer, these are figures from, I believe, 2020, which are, will be about the same in 2021. You can see if you combine both males and females, deaths from pancreatic cancer are actually over 45,000. And it's estimated that pancreatic cancer is going to become the #2 cause of cancer death behind lung cancer in the next year or so. So even though the incidence is lower, because the prognosis is so grim, the death rate is actually quite high for pancreatic cancer, surpassing that of even breast cancer. And here you can see, see the incidence it's much less so with pancreatic cancer, but deaths in 2020 were actually higher with pancreas compared to breast cancer. So what are risk factors? When I see a patient, in clinic and they've been diagnosed with pancreatic cancer, they always ask, doc, what did I do to deserve this? What could I have done differently? So I just quote the most common risk factors, as we know, are tobacco abuse. So there definitely is an increase in pancreatic cancer in those who smoke, diabetes, obesity. These are things that can lead to pancreatitis or inflammation, increased inflammation in the pancreas. You can add alcoholism to this list. So really anything that would result in frequent bouts of pancreatitis, pancreatic inflammation, is going to increase one's risk for developing pancreatic cancer. I didn't put genetics on this list. Of all cases of pancreatic cancer, I would say 5% or less are actually hereditary. So the majority are really not linked to genetics. Typical presentation, and this is probably not a surprise to you guys. So often weight loss, and it's pretty profound, easily 20, 30, 40 pounds of unintentional weight loss. The typical mid-abdominal pain that shoots towards the back as the pancreas, sits closer to the more of a retroperitoneal organ. Jaundice, if the tumor is in the head of the pancreas, then of course there will be obstruction of the common bile duct that will result in jaundice. Patients will complain of acolic stools, dark urine, and then diabetes. This is something that's really being understood over the last few years, is that patients with a new diagnosis of diabetes, that could be the first onset of pancreatic cancer, that we just don't know it yet. And so it's not uncommon. I see a patient with pancreas cancer and they just happen to be diagnosed with diabetes like a year or two prior. In terms of diagnosis, so CT scans are really the hallmark. And so anytime I speak with primary care physicians, I always encourage them to, if you have any doubt, just go ahead and get a CT scan. Oftentimes, historically the teaching 10 years ago was you get an ultrasound. Based on that, if that shows a lesion, you could then get a CT scan. But the ultrasound is negative, you might stop. And certainly, I don't want to, because I'm an oncologist, everything that I see ends up being cancer. But, I just feel like an ultrasound, a transabdominal ultrasound is not adequate to rule out a diagnosis of cancer. And so if somebody's coming in with weight loss or abdominal pain, honestly, I would just skip the ultrasound and go straight to the CT scan because you're not really going to get much from the ultrasound. Endoscopic ultrasound is something that is done typically once you see a mass on the CT scan. So if you identify a pancreatic cancer mass, excuse me, a pancreatic mass, then you would go ahead and send the GI for an EUS, and that's when they would do the biopsy as well. Certainly, CA19-9 is not a good screening modality, but once you've made a diagnosis or once you've identified a pancreatic mass, then you can go ahead and get a CA19-9. Keeping in mind that a CA19-9 can be elevated into the hundreds with just any kind of biliary stricture. So you can have a benign process that will result in an elevated CA19-9. That doesn't necessarily mean it's malignant. And the CBC and the CMP are done, but again, these can often be normal even with the diagnosis of pancreatic cancer. In terms of staging, so we typically think of cancer stage 1 to stage 4. With pancreatic cancer, I often tell patients that I think about it more so in terms of like resectable, borderline resectable, locally advanced metastatic, because that's really is going to be how you're going to treat patients. And so stage 1 to 4 is often misleading for pancreatic cancer patients. And the resectability, whether it be one of the first 3 categories, is really based upon the involvement of the adjacent vessels, the SMV, SMA, portal vein, et cetera. That's going to determine how you're going to treat your patient. So here you can see this is considered like perhaps a borderline resectable case. And you can see here is the pancreatic mass. And you can see, I believe this, let's see, I believe this is this is an artery here, and there's some vein involvement here. You can see some abutment of probably the SMV there. And so resectability, again, is going to be based upon abutment of the SMV and the SMA. It's really a surgical call. So the surgeons will determine based on the vessel involvement whether or not the patient is resectable. And that's why it's important to get high quality CT imaging with cuts through the pancreas at 2 millimeter intervals. So for resectable disease, so this is like a best case scenario. You've been diagnosed with pancreatic cancer. You've been seen by a surgeon, and they've determined it's resectable. So the current standard of care is upfront surgery. So a patient will go straight to the OR for surgical resection, followed by adjuvant chemotherapy. We do chemo as an adjunct to surgery. The goal of the chemotherapy is to reduce the risk of recurrence. That's the current standard of care. However, that's changing a bit because the risk of recurrence is still so high. So even after having a resection, the risk of recurrence is still approaching 60% even with chemotherapy. And so that's still inadequate. And so many centers are now looking to improve that statistic by giving chemotherapy first. So here's the standard. You have surgery, you recover, and then you have 6 months of chemo. The hypothesis is that you have your surgery, you've got 12 weeks to recover because it's a big Whipple operation. It takes time to recover. During that time frame, from initial diagnosis to actually starting chemotherapy, it can easily be 4 or 5 months. And we know that pancreatic cancer has a very high risk of metastasis. And so the concern is that the patient can actually develop mets prior to starting chemotherapy. And so it's changed our thinking a bit to using what we call neoadjuvant treatment, where we actually give chemotherapy at the time of diagnosis initially to potentially treat any metastatic disease that we can't see. We'd call it a micrometastatic disease. You want to give chemotherapy first in case there are micromets you cannot see, rescan after 3 months. If the tumor is resectable, you then will go to surgery, resect the tumor, and then complete chemotherapy afterwards. So this approach is now actually there's actually a clinical trial. I don't think I have this in a slide. There's a clinical trial, a phase 3 clinical trial that just opened up literally a month ago, where they're randomizing patients with resectable disease to the standard approach of surgery, recovery, chemo, versus chemotherapy, surgery, and then more chemotherapy. It's a study, a phase 3 study that's powered to show a difference in overall survival. And the question is, by doing neoadjuvant chemotherapy, will we improve the overall survival? This is this is a US study that's being led by the group at Dana-Farber, and will hopefully give us the answer of whether or not we should shift our current standard of care. We will also be a site here at Georgetown participating in that study. Just to go back on some of the pros of neoadjuvant therapy. So one of the problems with upfront surgery is what we call the R1 resection rate can be high. So when a surgeon operates in cancer, there can be an R0, R1, and R2 resection. An R2 resection is the surgeon operates but leaves gross cancer behind. So they just couldn't remove the cancer and they can see it visibly. An R1 resection is the surgeon thinks they got everything, but on the path, they see the margin was positive. An R0 resection is everything is negative, both gross and on path. And so by going straight to surgery, what we found is that the R1 resection rate, so surgeon thinks they got it all, but on final path, the pathologist can see a positive margin. That can be as high as 40% in some series. And so it's a problem because to go ahead and do this big operation, but then to leave behind a positive margin, you might as well not. And so by giving chemotherapy up front, the rationale is that you would decrease that R1 resection rate. And in studies from MD Anderson, it can be decreased to as low as 8%. In addition, some studies from Anderson, this is some older data, comparing survival at the time of like maybe 24 to 28 months. With this approach, the survival was approaching 34 months. Some of the cons with doing chemotherapy first are the quote unquote, you lose your window of opportunity. So patients could perhaps progress during that initial time period while they're on chemotherapy. And there's some discrepancy in terms of resection rates because in some series, the resection rates, the R1 resection rates were actually a little bit higher. So there's debate in the field. Some centers like MD Anderson always do neoadjuvant therapy. Others use the standard approach of chemotherapy, of surgery first and then chemotherapy. And this is a joke I like to share with the surgeons. Surgeons find they always got everything. Everything looks good, and it's a big operation with morbidity. And so you don't want to, be so aggressive that you've gotten the tumor out, you've given this aggressive operation, but then you left the patient perhaps, to a point where their life is in jeopardy. So you want to, you definitely involve your medical oncology colleagues when preparing for treating these type of patients. All right, we're going to shift to metastatic disease now, which is the majority of patients that I see. So I will say that of all new diagnoses of pancreatic cancer, 85%, at least 85% of new patients, when they're diagnosed, are already metastatic, stage 4. And so what that means is that the majority of patients with a new diagnosis of pancreatic cancer are going to have incurable disease. And so we typically can offer them chemotherapy, but not a surgical approach. For years, so from 1997 through maybe 6 years ago, the standard of care was a drug called gemcitabine for treating metastatic pancreatic cancer. And this study was a phase 3 study that compared a three-drug combination called FOLFIRINOX to gemcitabine, looking to improve overall survival. Here we can see the Kaplan-Meier curve. So the top line is survival for FOLFIRINOX, the bottom is gemcitabine. You can see here that the curves nicely separate. And so the median overall survival on this study for gemcitabine was 6.8 months versus 11 months with FOLFIRINOX. So this is an improvement of 4+ months in survival. P-value was significant, has a ratio of 0.57. So based on this trial, FOLFIRINOX became a new standard of care for the first-line treatment of metastatic pancreatic cancer. This is a second study that was done comparing, again, the previous standard of care, gemcitabine, to a combination of gemcitabine plus a drug called nab-paclitaxel, which is otherwise known as Abraxane. It's a taxane chemotherapy. This study was very similar, except it allowed patients who are a little bit more frail to enter onto the trial. So ECOG performance status of 0, 1, and 2 versus the previous study, which was just ECOG 0 and ECOG 1. On this study, you can see, again, the experimental arm did better than the gemcitabine arm, improvement in survival from 6.7 months up to 8.5 months. That was significant. And so this combination of gemcitabine and Abraxane was FDA approved about 4 or 5 years ago for the treatment of metastatic pancreatic cancer. So we have 2 options for treatment now for first line. We have FOLFIRINOX based on this trial, and we have Abraxane based on this trial. So for first line patients, if they are a little bit more frail, a little bit older, we'll use this combination. If they're more robust and healthy, we'll use the 3-drug combination with FOLFIRINOX. Future directions. So I mentioned genetics earlier. So even though the majority of patients with pancreatic cancer do not have a genetic link, in patients with a genetic link, a genetic predisposition to developing pancreatic cancer, BRCA by and large is the most common. It probably represents probably 5 or 7% of patients have a BRCA mutation. And so BRCA, BRCA is, as you are aware, is a gene that's important in homologous DNA repair. And so based on work done in breast cancer and ovarian cancer, we found that if you use a PARP inhibitor, so when patients, when a person has a deficiency in a BRCA, they cannot adequately repair DNA. They kind of revert to using a homologous recombination repair proteins, which are known as the PARP enzymes. And so you kind of like shift using the PARP enzymes to help repair. If you block PARP, now you've blocked off both pathways. So you're BRCA deficient and you blocked off PARP, now the cell dies. So it's kind of like a double hit. And so in breast cancer, patients were treated with PARP inhibitors, and they found that there were improvements in outcomes when you use PARP inhibitors in BRCA mutant breast cancer. Based on that data, this was extrapolated to pancreatic cancer. So olaparib is a PARP inhibitor. And so in this phase 2 study, patients with pancreatic cancer were given a PARP inhibitor, olaparib, and treated. And what they found was that the response rate, so the percentage of patients who had a measurable response of their cancer to shrink down, was 21%, which is really good in pancreatic cancer, telling us that the PARP inhibitors were perhaps effective in pancreatic cancer. So again, you're BRCA deficient, you cannot you would normally revert to using the PARP enzymes, but you block PARP, so now you're BRCA deficient, you've blocked PARP, you're double hit, the cell dies. So based on this data, a large phase 3 study was done across the world a couple years ago, looking in patients with stage 4 pancreatic cancer who were BRCA deficient. They were treated with chemotherapy for 4 months, and then they were randomized to placebo versus a PARP inhibitor for maintenance therapy. So once their chemotherapy was stopped, they were treated with placebo versus maintenance. And what they found was that when they were treated with the PARP inhibitor, the progression-free survival, so the interval at which the tumor did not grow, was 7.4 months versus only 3.8 months with placebo. So a much longer interval of cancer stability with the PARP inhibitor. So based on this data, olaparib was FDA approved for the use of maintenance therapy in BRCA deficient pancreatic cancer. This was the first targeted approval for pancreatic cancer. It was a very big deal, offering a new option for our patients. The last topic we'll discuss is immune therapy. I'm sure you guys have heard about immune therapy. Essentially, we think of the immune system as a mechanism of eradicating any kind of foreign body from the human body. So whether it's infection, whether it's cancer, the immune system is designed to recognize something as foreign and remove it. And obviously works really well for infection. You've got the recruitment of various inflammatory cells that help you clear an infection. We all think about this, now during the pandemic with COVID and such. What cancer does, so cancer is foreign. So ideally, the immune system should recognize cancer as foreign and attack it. The problem is that cancer is really smart. And so what cancer does is essentially inactivates the immune system. Basically, it finds a way to evade the immune system. And so what immune therapy does is immune therapy just basically takes away that blocker. And so when the patient receives immune therapy, it's allowing your T cells, it's allowing your immune system to recognize cancer as foreign, to attack it, and eradicate it. And this has been a huge breakthrough in oncology. So the most common immunotherapy options are PD1 inhibitors. And so this is called a waterfall plot. And so this is a study that was done in patients with not only colorectal cancer, but also a non-colorectal, we call it mismatch repair deficiency cancer. So the mismatch repair proteins or enzymes that help again with DNA repair. And so what was found was that in tumors that are deficient in mismatch repair proteins, they are thought to be susceptible to immunotherapy. And so we can see here the black graph are patients with deficient non-colorectal cancer. So this included like some pancreas cancer, some bile duct cancer. You can see when they were given the immune therapy, there was a significant shrinkage of the tumor. So 1, 2, 3, 4, 5 patients had a greater than 30% shrinkage. And this is kind of the hallmark of a response. And then you can also see colorectal cancer here. So the mismatch repair deficient colorectal cancer, there were 4 patients who had a response and a 5th that had a near response. So all these patients had their tumors shrink with immune therapy, and only a few, so 2, had their tumors grow. All the red are people who were not deficient in their mismatch repair enzymes. And so what this tells us is that when you are deficient in mismatch repair proteins, you're likely to respond to immune therapy. And so based on this trial published about 4 years ago, PD1 inhibitors became approved for a deficient mismatch repair deficient cancer, any kind of cancer. And the most common drug is pembrolizumab, which is Keytruda, also nivolumab, was FDA approved. It's really been a game changer because these drugs are fairly non-toxic, administered once every few weeks. Patients feel well, and the cancers can shrink down really nicely. So they're really amazing drugs to work with. Going back to the case I presented, the patient ended up having a CT scan. That scan showed, unfortunately, pancreatic mass with multiple liver mets. Biopsy confirmed pancreatic cancer. When I initially designed this lecture, she was on chemotherapy with FOLFIRINOX. Unfortunately, she did progress on chemotherapy. I put her on second-line chemotherapy. She progressed again. I tested her tumor. She did not have any mutations that were actionable, and unfortunately, she passed away from her disease a few months ago. Pancreas cancer is definitely a humbling disease to treat, but also inspires us to continue to work on research to develop better options for treatments. So, in conclusion, pancreas cancer is currently the third leading cause of cancer death. It's going to become the number 2 cause of cancer death in the U.S. in the next couple of years, just behind lung cancer, surpassing colorectal cancer. Early diagnosis is critical. The only way to cure this disease is to resect it. And as I mentioned previously, the vessel involvement can make surgery more difficult. And so the earlier we catch this disease, the better the outcome is. When patients present with symptoms that are concerning, CT scans are critical. Ultrasounds are often inadequate, and you really need a 3D cross-sectional imaging to determine what's happening. And then again, we need to continue to do research on pancreatic cancer because the incidence is on the rise, and although we've made improvements in treatment, we still have a long way to go. And so we definitely need to continue to work on new options for drug development.